So my study ACR was a phase 2 single-arm study looking at a bit of a novel treatment paradigm where in patients with low volume, we call it oligometastatic kidney cancer, what we were looking at radiation therapy without the standard of care systemic therapy to control the patients. In addition to the clinical results of this trial, we also had data on a very interesting circulating tumor DNA assay that we found to be prognostic for these patients. The study design was a single-arm phase 2 study in which patients with clear cell renal cell carcinoma with up to 5 sites of the disease received radiation to all active sites of the disease. They then went on surveillance with standard of care imaging, usually a CT scan every 3 months. And at the time of progression, the progression was limited, meaning up to 3 sites. They then went around again and had another round of radiation therapy and then retained off systemic therapy. In the event that the progression was not limited, meaning more than 3 sites, then patients were started on systemic therapy and they were off the active component of the trial. The primary endpoint of the trial was systemic therapy-free survival, which we powered it to detect an improvement that was greater than 2 years. This is based on a historical control with surveillance alone. So the primary endpoint was met in this study. The systemic therapy-free survival was 34 months with a confidence interval with the lower bounds being 28 months. And this exceeded our pre-specified threshold of success, which was 24 months. So we ultimately concluded that the study was successful. In addition, the other primary endpoint, I should say, a progression-free survival, which was more exploratory, was also found to be 18 months, which was highly promising. Furthermore, overall survival did not seem to be compromised in the patient cohort. The 3-year overall survival was 87%. And the toxicity rate was quite modest at about 6 to 7% grade 3 higher toxicities. In addition, with regards to our correlative analysis, the circulating tumor DNA was found to be detected in the majority of patients, and this ctDNA was found to be prognostic, both at 3 months for systemic therapy-free survival and at the follow-up and at baseline. So at both time points, we found that baseline is 3 months, that circulating tumor DNA was prognostic. So I think the importance is that the primary treatment for patients with metastatic kidney cancer, regardless of your low volume, high volume, is double systemic therapy with a PD-1 inhibitor and ipilimumab or T-peptide kinase inhibitor. And these are effective treatments. They've really improved outcomes in kidney cancer, but they're expensive financially, either to the patient or the healthcare system. And they have toxicity rates reported to be between 40 to 80%. Now, the reason why this is beneficial is that we found you could be off these drugs for at least 3 years with radiation therapy and other metastasis-directed therapy, and the costs are substantially less by order of magnitude, and the toxicities are also by order of magnitude less. So it's an option for select patients with low volume disease that you can get some high quality, relatively minimal healthcare exposure with radiation alone. And there's no evidence at this point that doing this strategy is going to make systemic therapy less effective later on. Yeah, so I think the other thing to add is that there are no good biomarkers in kidney cancer what we found was circulating tumor DNA, which is a very promising marker in multiple histologies, which was always thought not to work in kidney cancer because kidney cancer is considered to be low shedding and relatively have less genetic mutations. We found that it was with the second generation assay utilized by Myriad that this was a promising assay that you could detect the majority of patients with low volume indolent disease, and that this detection was prognostic of outcomes. So we feel that that's implications not only for this setting with oligometastatic, but possibly other settings as well. Those were more higher volume metastatic disease receiving standard of care systemic therapy, or those post-nephrectomy who are thinking about adjuvant systemic therapy.